On behalf of JourneyCare and JourneyCare Foundation, Diane and I would extend our warm welcome to you to this Legacy Society dinner. And I'm delighted that so many people are here tonight, despite the TV distractions. And I'll only say one thing about that. And Diane is shuddering. What's he going to say about the election? Nothing. I'm only going to say that if someone asked me to give advice to the Chicago Cubs, unfortunately nobody has, but if they had, I would just simply explain to them that you cannot win a baseball game without scoring any runs. So. Oh, thank you, Jack Trump. But at any rate, our plan was to conclude the program by 8:15, but as usual, since everybody was having such a good time at the cocktail hour, we're running a little bit late. But at any rate, the primary purpose of the Legacy Society dinner, annual dinner, is to give us an opportunity once a year to tell all of you how grateful we are for your incredible generosity. You know, because of your generosity, we serve several thousand patients, family members each day with a wide variety of services in a 10-county area in Chicagoland. And because of your generosity, we can do things such as offer services that are not covered by medical insurance, such as our medical therapy services. And very importantly, we can offer services to families and patients who cannot afford to pay for the services. So because of your generosity, JourneyCare is in a position to never have to say no, and that's where we want to be. So on behalf of all the patients, family members that we serve, that you've helped us serve, we thank you so much. I'd like to introduce Joe Maddie, who is the new president of the JourneyCare Foundation. Joe came to us in June from Northern Illinois University, where he developed and implemented an extraordinary program of advancement for NIU. I've had a chance to work with Joe on a number of things since he's been here, and I can tell you that he is a dynamic and dedicated development professional, and we're very lucky to have him. So it's my great pleasure to introduce to you Joe Maddie.
Can you please give Mike and Diane Beemer a round of applause for tonight? Tonight I was going to say almost everything he said, so yes. But for us in the foundation, tonight isn't one of those nights. It's kind of like the Oscars or the Emmys. We get to see the people that we want to see year-round. We get to see the people that make our jobs possible. And we get to say thank you. If we don't say thank you to you at least 100 times tonight, we are not doing our job. You are making the lives of so many people better because of your generosity and your leadership. No one knows the mission of JourneyCare better than you, the individuals in this room tonight. 20, 30 years ago, you had the vision to be able to start an organization that put others first. And for that, we are grateful. There are people in the inpatient unit today that are thinking and thanking you for what you do. So again, on behalf of JourneyCare, I want to say thank you. But no nonprofit can just do it alone. We have an extraordinary leadership team, and we have 2 extraordinary boards. We are lucky to have a CEO in Sarah Beals. Sarah, please stand up. I don't know if you know this, but running a nonprofit's hard. And the state of Illinois does not help you. With Sarah's leadership, we're able to have a merger that is going to affect change throughout this country. We are the 6th largest nonprofit organization for hospice and palliative care in the country. You cannot do that alone. We have board members on the agency side and the foundation side. If you can please stand and be recognized. I have never seen so many people want to do 7:30 a.m. conference calls than this group of people. And I'm thinking, I'm excited and I'm energetic, and they're on the phone. I'm like, oh my God. That's leadership and dedication. And we all know a nonprofit cannot exist without a strong leadership team. And many people think nonprofits, they're like, oh, they're going to leave at 8 to 4:30. It's an easy job. More times than not, 6:30, 7 o'clock at night, my colleagues, if you can stand, the executive leadership team, please stand. They're here working on behalf of our patients and their families. Our entire executive leadership team is basically here tonight. And they, you know what? They're here because they want to say thank you. They're not all at one table hanging out, saying, oh, we could be watching the debate or the the Cubs. They're here tonight to say thank you to you. We are lucky to have our philanthropists with us tonight. Many of you give to a lot of different organizations, and we will not say stop doing that, because what you do makes a difference throughout this region. But we want to say thank you, and we're going to be able to say thank you, and we hope you have the best evening compared to any other organization you support. So at this time of the night, I just want to once again thank you. We have a fun evening planned for you. We are lucky to have Dr. Jeffrey Vender. Dr. Vender, can you stand up, please? Dr. Vender will be emceeing this evening's case study. We have Dr. TWADDLE and Dr. ROTHENBERG. Please stand up, both. I'm going to say I went to medical school after tonight, just so you know. We're here because of the patients that we serve, and we're here because we have extraordinary leadership, and we have extraordinary donors. The one last thing I wanted to leave you with is, before you leave tonight after the case study, we're going to be giving tours in the Marshak Family Care Center, because we believe our philanthropists should know where your money is going to. We believe that you should understand the impact that you're having on the lives of people. If you have time, it'll take about 1 or 2 minutes just to take a walk through and just understand the impact and magnitude you have. At your place setting, you're going to have the case study, so if you want to read about it and talk about it at dinner tonight, so you're prepared, study up. And then we're going to have dinner now. So at this time, my colleague Annabelle will be calling tables. We ask that you stay seated until your table is called for dinner. But before I take away or shut the microphone off, again, we would not be here without your support. We want to thank you for everything that you do, and we hope you have an enjoyable evening. Thank you. I hate to interrupt good dinner conversation, but I think this is the exciting part of the evening why a lot of us are here. We're going to be hearing from 3 doctors in a few minutes. We're going to be going over the case study at everybody's table. This is an opportunity for us to kind of interact with each other, ask questions, and really just to understand what our doctors are doing, our nurses, on a day in and day out basis. I'm going to be introducing Dr. Vender. I had the opportunity to meet Dr. Vender for the very first time at our golf outing, which was held a couple of months ago. And going up to the event, Ann Rossiter, who is my colleague, was telling me, he's an amazing man, you're going to love him, he's great, he's energetic, he's this and that. So I go up to him like, hi, Dr. Vender, I'm Joe Madden. Yeah, that's great. Where do I do so? I was like, oh, thank you, sir. And his wife was sitting next to me, and she started laughing. She goes, yes, I'm used to this. So please join me in welcoming Dr. Vender.
Actually, that story is 100% true, because I knew what Joe's job is, and it's raising money. So I got away from him as quickly as I could. I got to hold it up here. Is that a little better? So I was listening to the comments, and the first thing I want to do is thank Mike and Diane for the continuation of the legacy and all that they have done in the past and present today to allow the organization to thrive the way it has, as well as their friends and all of you who are here. Very important point. And Mike alluded to the fact about thanking everybody. So I thought I'd take this opportunity to do something very rare. I'll thank my wife. Thank you, Bobby. That goes a long way when you live with me, trust me. Who said she's a saint? Are you kidding? A couple preliminary comments, and then we'll move on. I'm a relative newbie in this crowd. I've only been involved here for 15 years. And by the way, when I see Dennis Murphy and a number of others here, Meade Montgomery, I don't want to pick out individual names. I am a newbie. 15 years as a beginner. But I've seen the growth of the organization from Evanston and before to these two magnificent facilities here, and today part of JourneyCare, a much more significant organization with major challenges of their own, because with growth comes challenges. I had the pleasure, when you talk about newbies, of knowing the two primary speakers tonight for this short program, Dr. David Rothenberg. We're really not doctors, we're anesthesiologists, you know. So nobody cares about us. We're insignificant. We didn't even go to med school, and when you get the bill, you wonder what we did. You're not a surgeon, you're not an internist, you're just somebody. That said, David is a rock star critical care anesthesiologist from Rush Press St. Luke's, a small community hospital that we don't really recognize on the Eisenhower Highway. And then Martha TWADDLE, who is now a nationally prominent palliative care hospice physician, nationally prominent. Now, I knew Martha as a house officer, resident, and intern at Evanston, now North Shore. It's really hard to believe, Martha. I knew her very well during training, and it overwhelms me to think what she has accomplished, and it shows how far you can take a good story, and you've done a great job. That said, now all of you have something in front of you. You have this little case study. And if you're like me when you watch the debates, which we'll get you to, or the Cubs game, which was 0-0 the last time I looked, so you haven't missed anything yet. Nothing good, nothing bad. Nothing good, nothing bad. But this is what we call in medicine a case study. And I really would like everybody to read it, but I'm going to read it out loud, because this is the basis for what we're going to talk about. I'm going to have Martha and David join me up here now. I'd rather have Sherry come up, but I'll take you, David. A call comes in from friends and family looking for help for a recently widowed 50-year-old woman. Point one, we're talking about a 50-year-old. Many of us are long beyond this. And my preface there is, when I got involved 15 years ago, I thought this was a great organization. 15 years later, I'm feeling it's greater, if you know what I mean. The woman who we will call Ann was diagnosed with stage 4 breast cancer less than a year prior. Stage 4 is the worst kind. She is fiercely independent and tenacious, working in finance, and she is very successful in her own right. Her husband was diagnosed with stage 4 lung cancer, also the worst kind, at the same time as she, and he has since died. During his illness, she postponed her treatments, and her disease progressed, as would be expected, now involving the lining around her brain. Her goals of care are to beat the disease and resume further treatment. That's her goals. Her family and physicians see that she is now unstable in walking, intermittently confused, with significant weight loss. Her physician believes that her prognosis is measured in weeks. They are at a loss of what to do. And the question is about them, what would you do if you were the patient? So before I turn this over to David and to Martha, I want everybody to reflect on this. And there's several, I don't know if any of us are 50, but there's probably a couple people in here who are 50. I mean, there you go. Okay, there's always somebody good. I mean, I can't imagine the situation. Now, my mother died of breast cancer at 51, ironically, but I was much younger, and it's hard to reflect on, you know, what 50 is looking forward. It's very easy to reflect on what 50 is looking back. And this is a successful, enterprising individual. So now put yourself in that situation. You've had a spouse die, and you've got a terrible prognosis disease. And you saw the condition. many people here would just basically surrender to the situation, I would assume. And others, depending on their family situation, their desire for life, their own personal attitudes and religions, would choose to fight on similar to this woman. But that's a decision that's worthy of every person who's sitting here thinking about in the context. I don't care if you're 50, 60, 70, 80. That choice will be every one of ours at some point if you are cognizant of your environment and enjoying what you have today. So with the question unanswered, because we're not going to poll everybody because of time, I would like to turn it over first to Martha. And I want to say my view of this case doesn't say one important thing. They talk about her physicians. And one of the things people like Martha, and David's an intensive care doctor, and he gives a talk on end of life, do not resuscitate, that was done here, that if you've never heard it, it's brilliant. And it's done without slides, contemporaneously, with a lot of passion. This is why he works at Rush. He's trying to elevate his game. So if you've ever worked with oncologists, which both of these people have, we all need them when we have cancer, but they have one mission in mind, and that's to cure your cancer. And anything short of a cure, I don't want to say is a failure because there's the realities of the disease, but that's their motivation in concert with you as their partner. And then there's the critical care doctor and the palliative care hospice physician. So Martha, I'm going to turn it over to you.
Greetings. I'm going to give it to Dr. David sooner than later because I'm actually going to just set the stage and I want Dr. Rothenberg's comments. What I wanted to say before I give it to you is part of this story is to show you what we walk into, that it's not neat, it's very messy, it's very complex, and I think that this story, this woman's story, points to the psychosocial, the spiritual, the needs that are far beyond simply a disease. So that's the first thing that challenges us as doctors is it's not neat and tidy. It's not one problem, it's many. So, and I'll get back.
Finally, I never thought I'd get the microphone. Anyways, thank you, Jeff. Thank you, Martha. It's a real honor for me to speak to you folks again. For those of you who were here last year, this is a little bit of a continuum in our conversation, if you will, that we had. And I prefaced a lot of my comments last year about medical ethics, if you recall. And we talked about certain words that we use in our lexicon, things like beneficence and non-maleficence, doing good, not doing harm, right? And in this situation, as you look at this patient, what we have to look at is what's good, what the patient thinks is good, not what I think is good. All of you read this, heard this case, may have prejudged it, like most people, God forbid that's me, don't do anything, or whatever else you're thinking of in your mind right now. But she has wishes based on her desires. They may not be realistic, right? They may be, to a certain degree, if you recall, we talked about things that were futile last year. Maybe there's some futility aspect, but right now we're dealing with her perspective on what she thought her quality of life would be, right? And that's doing good. We have to respect that. Non-maleficence, however, as a physician, I can't do harm. And the harm may come in my role as an intensivist, could come into play, if you remember our conversation last year, of me saying to her, okay, depending on the nature of your brain involvement right now, you may be coming to me as in my other hat as a neuroanesthesiologist requiring brain surgery. And what happens if things don't go well and you end up on a mechanical ventilator or requiring other types of what we would consider, remember the words I used last year, death-delaying therapy? Supportive in our lexicon as well, but maybe not prolonging your life, but prolonging your death. What would you want in those situations? I don't know if we're there with that patient because I'm not sure where we're going to go with this case. Martha's going to have far more insight into that. But if this patient was to come to me as an anesthesiologist now, and then eventually as an intensivist, my conversations would be, you may require surgery, okay? And if so, depending on the nature of, if this is a brain tumor, and I do this far too often on a far too common basis where patients come with metastatic disease from lung cancer, breast cancer, and we're doing neurosurgery, taking out that particular brain tumor, knowing that that's not curative, that to a certain degree it's palliative, meaning that we're going to hopefully improve their quality of life, which is why we do surgery. If we're not improving quality of life, why are we doing things, right? And we've talked about that a little bit last year as well. So if this turns out to be a potential surgical problem, then my colleagues, neurosurgeons and others, oncologists, have to say, look, we could do this, but you're only going to get 3 months of life based on our data. Well, far be it for me to say what those 3 months could mean to that person, right? That's her decision based on her quality of life. And so even though her words are, I want to beat this disease, that may not be realistic, but at least relative to quality of life, we may be able to offer her something. My role would be to be able to say to her, if that's where we're going down what road is, what happens if things don't go well? What happens if we take you into the operating room, do this brain surgery, and something happens that I can't get you off my mechanical ventilator that's keeping you alive to improve your quality of life, and I have to take you now to my intensive care unit where you're now on a mechanical ventilator. Maybe I have to support your blood pressure. Now you start to lose more neurologic function. We have to have a plan going in. You've heard these terms, right? Advanced directives. Very rarely do doctors, especially surgeons, and this isn't, and Dr. Vendor knows this, no affront to any surgeons in the room, they don't like to have those conversations. You should know that as patients. Surgeons don't like to have those conversations because their role as a surgeon is sort of that knight in shining armor that's going to write. They're there to help you. I've had these conversations with surgeons before. Their job is to treat, not to say I can't or I shouldn't, because the patient's coming to them and they feel the obligation to do that, even though that's not necessarily true. The obligation should be do what's right, do what's, what you can for this patient, but within the realm of not doing a procedure where you know it's not going to work. So if that conversation is had with this patient and we proceed, I have to be able to say, what do you want me to do to the patient, not to the family, because I don't want that burden on the family afterwards. Remember we talked about that burden last year when doctors would go out and say, what do you want us to do? Well, I don't want to be able to have that. I don't want to have that conversation. I want the patient to decide. She's making this decision right now. And if you tell me, look, I want you to get me through this as best as you can, but in the event that we end up, you can't wean me off the ventilator, you can't wean me off some of these supportive measures, death delaying, however you want to cause it, then my wishes are to let me go, to withdraw support, not care. Remember we talked about that last year? I never withdraw care. I only draw support. And then I say, okay, we enter into a different phase of care. Not critical care, palliative care. And then I turn it over to my colleague, Dr. TWADDLE. Or maybe, if we're lucky, we have those conversations together with that patient beforehand. I have to be honest with you. As an intensivist for many years, very rarely did I have the opportunity to have those conversations. It's sad. It's what needed to be done, because I'm getting it on the back end after the surgery's already been done. And now I have to say, did anybody have these conversations? If not, now we have to struggle, because a lot of times the family doesn't really know. But then we have to have those conversations if she can't speak for herself. So this is how I would handle it this is what I would do at this point. And if surgery is a consideration, we'll get you through it as best as we can. If we can't, we want your safety net, if you will, to say, I'll help you down. Remember we talked about that tree, the technological tree here? I'll be the one to help you down the tree and let you go with dignity with the help of my colleague. I'll turn it over to Dr. TWADDLE.
Thank you for that, David. That's fabulous. The other thing that highlight here is our greatest teachers as physicians are people like Anne. I had a great teacher there in Jeff Vendor, definitely. But the people who really teach us about what it means to be ill, what these illnesses look like, are the people who live and die with those illnesses. And Anne's story, she was a phenomenal teacher, a young woman with serious disease. And when asked to see her, this was one of those where the family called and then called back and said, don't come, and then called and said, do come, and then called and said, don't come. So I finally said, I'm just going in. I don't know what I'll find, but I'm just going in. If looks could kill, she was not happy to see me. Her physician and her family felt the team needed to be there, but she didn't want us there. And I asked her what her goals were, and it was to beat this disease, to get better, to be riding her horse again, and she was going to show me. And what this highlights is that we have this name called JourneyCare, because people have a journey that is uniquely theirs. And we all talk about all the time meeting people where they are and walking alongside them and learning what it is that they value and shaping the care to support them in that care. So my response to Anne was, she qualified, interestingly, for hospice care. She had a hospice benefit, or we were able to make a hospice benefit for her. She definitely qualified. She had a prognosis defined in terms of weeks. She had what was called, and this is a word to use at dinner, leptomeningeal carcinomatosis, which basically means that the breast cancer had grown along her brain and was coating her brain, and it was no longer a surgical illness, it was a diffuse illness. And in talking to her, I said, how do we honor your goals to get better, while at the same time supporting you in creating a safety net, just like Dr. Rothenberg was saying? And I asked her, who in your family would benefit from increased support? And I explained to her what hospice was and what home care was, et cetera. And she said, you know, my mom needs hospice. Not because her mom was sick, but because Anne was sick. She said, my mom needs that. And that's another point, is that when we care for people, it's not just a person in isolation. It's for them and their family and those who love them. And sometimes they're doctors who care about them too. We support them. It's really about a village taking care of a village. She had an 81-year-old mother who was her primary caregiver. So we started care. We worked with her insurance company, this was many years ago, and cobbled together a hospice benefit, which would allow us 24/7 responsiveness, nurses visiting the home, physical therapists, social work, the whole 9 yards. While at the same time, she was in our face to say, I'm going to beat this, I'm going to get better. Her oncologist called one day and said, Martha, I don't know what to do. She keeps coming in for appointments and asking me to treat her. And I said, Leon, some of you know Leon Dragon, magnificent oncologist, now retired. I said, Leon, what can you give her that will create no side effects, non-malfeasance? So don't cause harm, but is there any therapies that you can give her that will promote perhaps some symptom control and really treat her as a person, because this is what she wants. And he says, I don't think it's going to do a thing for her. I will give her some therapy. And I think that would really help her, spiritually, socially, but not physically. Well, here's the other miracle of our work. Anne's disease melted away. Every time I went to see her at home, she was better. Where she'd been cross-eyed, her eyes went straight again. Her speech normalized, her gait normalized. She started to eat, she started to gain weight. The physical therapist was called back in. She graduated from hospice into home care. I arranged for her to have a personal trainer. She called me from Home Depot and asked me if she could get me anything. Seriously. I got a page one day from Anne. I'm at Home Depot. Do you need anything? And she started laughing. She lived an entire year. And in October of the following year, from her diagnosis, almost a year to the day, the disease came back. And she looked at our team and she said, I don't want to go to the hospital. All I want to know is that I can stay home and that you'll be there for me. She died at home with her mother and her priest by her side. This was such a lesson for me of meeting people where they are, helping them to live large until they die, and also the miracles that we get to witness in the care that we do each day. Because we know when we start that journey, we have no idea what it's actually going to be like. We just want to be along for the ride. So thank you, every one of you here today, because you help us say yes and cobble together insurance benefits and figure out ways to meet the needs of amazing people in our community that very much need our care. We're very grateful. Thank you.
Now you feel bad I didn't give them the mics earlier. I know what you're thinking. I know the evening is late, but while we have the benefit of two very brilliant, passionate, and empathetic physicians, and you heard that in their discussion, any questions? Yes, please.
Help to promote what you're doing here. maybe more in the city of Chicago, which is where I'm living now. And how do you teach doctors how to speak to patients? That's really, really critical.
Only because I'm the moderator, I have strong opinions. I'm going to give it to David first.
You know, is that on? It's an excellent question, and I'll start off by saying it's very hard, and it's much harder than it ever used to be. I'm not going to claim old school on this, but times have changed in medicine relative to the way things have practiced. I actually started in internal medicine before I went into anesthesia and then critical care. And many things that have benefited mankind have changed the way they practice at the bedside, not for the better. The best example, quite honestly, is this. Okay? The studies have been done. Our young doctors spend hours on this and minutes with the patients. Part of that is related to the fact that they have obligations. Everything's computerized. The government has mandated it. You don't get paid unless you have an electronic medical record. And people are on the computer. You've all seen this going to the doctor's office, right? Your doctor's typing with their back to you while you're the patient. And all it would take is something so simple as saying, pardon me, I know this seems rude, but I need to do this, and it would diffuse the situation. But our young physicians don't even know how to say that. And so to teach them end-of-life issues, to be with me when I was making rounds with family at the end of life, to say, sit with me and watch, like I learned from Dr. Vender and my mentors at Michael Reese of blessed memory, is almost a lost art, because the degree in which they're so in tune with the electronic devices. Part of the reason I retired from the ICU, not to call sour grapes, I've told this story many times. I used to round at the bedside. I used to have everybody at the patient's bed, and I would say if they could talk, do you mind if we stand here and talk about you? And if the patient said no, then I would go in the hall. It never happened. I had the nurses with me. We paid respect to the patient, and everybody paid attention because you were at the patient's bedside. When the computers came into the world, they were called computers on wheels, cows. We were literally herding these computers in the hallway. I couldn't get into the room, and people would talk while they were on their computer. I used to say, if the next person that types loses a hand, okay? And what happened finally was, we would present the patient in the hallway now. I turned around, walked into the room to see the patient, and I realized I was the only one in the room, because everybody was still glued to their computer. I'm concerned about this. This has been studied already. We know, people, we've lost the ability to write. No one's teaching cursive. Everybody's still on their computer. We know that they're now becoming less smart because of that, and can't do anything about it because they don't know how to write. And we're paying far more attention to the screen as opposed to the patient. I don't know how to do that anymore. You can't do it in a classroom. You can't. You have to be at the bedside and see it happen. You have to experience the death with the patient in order to gain respect for it. I didn't answer your question because I don't know how to do it. I really don't, and it's a concern.
So I have I think a more upbeat message. So this, yeah, I'm palliative care. I'm positive. So palliative care palliative medicine and supportive care is a medical subspecialty as of 2006. I got an email today from Dottie Pittner, who is our CEO here, and her daughter from her second marriage, and actually her granddaughter, take that back, her granddaughter is a medical student and was taking her exams, and there were questions specifically related to palliative care on her exam. Because we're a medical subspecialty, we did that so that we had to spend time with the medical students and influence their care. Every year I go for what's called boot camp at Northwestern with the new recruits and new students and the new residents. And what we do, which is standard now in all medical schools, is communication skills training. So a lot of this also is being promoted by our beloved Atul Gawande, who wrote Being Mortal, and Adriana Labs, which is the work out of Harvard in terms of communication skills. There's tons of research in how to teach physicians, nurses, social workers, but particularly physicians, how to communicate more effectively. And this Friday, we will spend an entire day. At Northwestern, we have a project going on right now with 36 hospitals throughout the state of Illinois, where we mentor them in developing communication skills for their professional staff And it really influences the culture of the hospital, not just the physicians, but how everyone interacts with people and their families in terms of sitting down, listening, and shutting up. It's really important for us.
One more question, Joe? Was there another question? Yes, Dennis.
Martha, it seems to me that you're telling us that the patient responded positively to the placebo effect. The placebo effect is not inappropriate. I don't know if the microphone is working. It seems to me that you're telling us that the patient responded to the positive placebo effect.
She actually got chemotherapy. He chose a low toxicity chemotherapy that she responded to, which was not easy to explain why she would have responded to that chemotherapy. The mystery of human beings.
Was there one other? I saw another hand up. Was there? Well, no. So I'll make two quick comments based on what Dennis just asked about, that they did get low dose chemotherapy, but there are multiple situations that many of us might be confronted with. I hope none of us are, and that is where you're in this dire situation, and somebody says, with the encouragement of positivity, that we can do this, this, and this. But what most people don't realize is some of the things we can do, as David said, have huge toxicities to it, and what ends up happening is you end up dying from the treatment and not your disease. And there's a very well-recognized study that was in the New England Journal of Medicine years ago by a Dr. Lynch at Yale. He's an oncologist at Yale, looking at lung cancer patients just like this, who one group got the chemotherapy and the other group basically got palliative care, but they were end-of-life lung cancer. The ones who got palliative care lived longer. They lived longer without therapy because of their state of mind, their state of consciousness, the non-toxicities of their treatment. So as much as we all want to preserve human life, that's our goal, it always has been, and that's the problem with acute care hospitals that many of us, that you alluded to. We go to work in an institution, we're trained, you know, David made his comments about surgeons, I don't differ from it, due respect, Richard. You know, they're trained to make disease go away. And the lack of ability to make disease go away is almost like a failure. And I used to use the expression when we were raising money years ago. I said, when Charlie Trotter's was a restaurant, I said, if you asked Charlie Trotter's to make fast food like McDonald's, they couldn't. And if you asked McDonald's to make gourmet food like Charlie Trotter's, they couldn't. Organizations like this, doctors like Martha and David, exist to manage situations that are no longer a matter of cure, all a matter of quality. I know the hour's late. Joe, did you want to close this up, please? I thank you all for your attention, in particular these two for their comments.
So I'm just going to take one last minute. Everybody in this room probably goes to 50, 60 dinners, events, galas a year. Every one of us has probably sat through a program of silent auction and so forth. Our goal tonight was two things. One, to make sure when you leave here, you know you are thanked and you are appreciated by JourneyCare. The second thing is to know that you are a part of an organization that is making a difference in the lives of people, and that when you're driving home tonight, you're thinking to yourself, that was a fun evening. Not because I got to see all these different people, but you were challenged mentally. And you are around people that want to make a difference. And that when you do write that check, and we thank you for the fact that you do, you know it's going to a good cause that you can feel proud of, and that we are going to steward your dollars appropriately. So with that being said, one last time, thank you, and please give yourselves a round of applause for what you do.